And I'll invite Dr. Shreyas Ramamurthy to talk about alternative indications for EVO ICL.
Thank you. Thank you so much, madam. Probably what you all witnessed in the last 8 minutes might be the most useful. All of us are talking for 2 hours on ICL and saying the same things again and again, but that was something really out of the box. So what I'm going to be talking about is alternative indications for ICL because I think all of ICL related material has already been covered. And I'll take you all through how phakic in keratoconus or irregular corneas, where it can be used, when not to be used, and what are the points to be kept in mind. So when stable keratoconus or because of age or already cross-linked, patient should have good spectacle corrected visual acuity. If there is a single take-home point from this presentation, it is the fact that the patient should be happy with the quality of vision they have with their spectacles, whether it is a 6.6 or a 6.9 or a 6.9 parts or even a 6.12. If the patient is very happy with their spectacles, you can correct them with a phakic intraocular lens. Centered versus decentered cone, I'll just touch upon it in a subsequent slide. Generally, we wait for a minimum period either with a cross-linking or after a topo-guided PRK or with an intracorneal ring segment. We wait for a period of 6 months at least to ensure that we attain stability before we go ahead with a phakic IOL implant. So like I mentioned, in a progressive keratoconus, in a central cone with good spectacle corrected visual acuity, you can do a topo-guided PRK plus with a cross-linking, and then after a time interval do a toric phakic IOL. If it's an eccentric cone, you could even do an intracorneal rig segment. And for a very low residual error with good pachymetry, you could do a topo-guided PRK. With a higher residual error, you could do a toric phakic IOL. Specific situations where it becomes very, very useful is now this is a patient with a very early KC which we are just observing in this eye, but the other eye which is cross-linked and has a significant KC. Now, the best corrected visual acuity with spectacles is very good, but look at the amount of anisometropia between the two eyes. This patient will never be happy with their spectacles, and if they don't want contact lenses, these are patients who will do very well with a phakic IOL in this eye and have excellent binocular vision. Even such patients with a significant power, with just a 624 BCVA, post intracorneal rig segment, their BCVA improves. Once their best spectacle corrected visual acuity improves, these also become good indications for a ICL. Now, I will also mention what precautions that we would have to take when we are doing an ICL for these patients. The implantation, the procedure itself is very, very similar. The only point maybe you'll have to keep in mind is that the edges of the intracorneal rig segments can hamper your visibility if the pupil comes down a little bit, and you just have to ensure that the haptics are well tucked in place. That's the only additional point as far as surgery is concerned. But we all know that there is a central ACD can be high in keratoconic patients, especially if the cone is steep in the center. The keratometry being high gives a falsely high anterior chamber depth. And this can result in a higher vault than what you would have normally predicted. For the same white to white, you might end up with a higher vault. For the same white to white, you might end up with a narrower angle as compared to in a regular patient. This is one example, although this is not an ICL, this can happen with an ICL or any other phakic IOL as well. As you can see here, because of the higher vault, it is tending to capture into the optic. So this is one additional point that you need to keep in mind, that the central anterior chamber depth may be overestimated in a keratoconic eye, and you would have to exchange it with a smaller sized lens. So as a general rule nowadays, we choose one size smaller in patients with a higher anterior chamber depth or a very high astigmatism. And of course, they may need customized lenses also. And here you are trying to give them the best possible outcome. We are not promising emmetropia in these patients. They may have a very subtle small residual error, but believe me, these are very happy patients. Again, avoid contact lens users, patients with best spectacle corrected visual acuity less than 612, and those patients, very importantly, not happy with the quality of vision. Even post-DALK, these can be used. This is again a patient with a very good spectacle corrected visual acuity in this eye, and this is a post-DALK patient where you can go ahead. I would not generally prefer to do it post-PK, although this has been documented and presented, because this endothelial cell loss could lead to graft failure. But with a DALK, that risk is not there, and you could. It's a very, very viable option in post-deep anterior lamellar keratoplasty patients. This is a quick study that I'll just present the results of this quick study of 126 eyes of patients who underwent ICL or toric ICL in keratoconic eyes, and we also included patients post cross-linking and post intracorneal rig segments. As you can see here, this is a slightly older age subset because they are keratoconus. We want to wait, and this is around 30 years, which is the mean. And also you can see that the Kmax is around 54, 55. So it's not a very high advanced keratoconus, but a mild to moderate keratoconus. And these are the results. You can see that despite being a keratoconic eye, where the subjective refraction itself can be a little variable, 90% of the patients were within plus or minus 1 diopter. Where they had excellent improvement in both their best spectacle corrected as well as uncorrected visual acuity. And there were a significant portion of patients who had a gain, that is 40% of patients had a gain of 1 or more lines. This is essentially because we are reducing the anisometropia, we are reducing the ametropia, the visual correction is close to the nodal point of the eye, and this really improves even their best spectacle corrected visual acuity. We looked at outcomes with low as well as high astigmatism, with less than 4 diopter as well as greater than 4 diopters of astigmatism, and even the high astigmatism subset did just as well as the low astigmatism. Even in decentered cones, when the patient has good spectacle corrected visual acuity, even with mildly decentered cones, these patients can do well, as shown in this study. So appropriate case selection, patients satisfied with best spectacle visual acuity with an emphasis on sizing can give rise to optimal results even in these patients. I'll just use one additional point regarding the toric phakic IOL, which can also be used as an option for a piggyback lens. This is a patient who had a high residual error after cataract surgery, and the capsule was already fibrosed, and you can even use a phakic IOL as a piggyback lens and correct these powers. Lastly, to leave you with, when we are looking at keratoconus, when you're looking at all these piggybacks, so many options, what about any of the regular refractive errors? ICL can correct any refractive error, gives us better visual acuity, better contrast sensitivity. There's, in fact, gain in lines of vision, which you see in if a post-phakic IOL, which you don't see with any excimer laser treatment. Greater predictability, you don't have regression, no epithelial remodeling, no epithelial hyperplasia, no induction of higher order aberrations. And most importantly, no initial cost as well. So for a center which is starting out with refractive surgery, if you're looking at a 3 crore investment of an excimer laser or just wanting to do phakic IOL, this is definitely an idea worth thinking about. Thank you so much for your kind attention.
Thank you so much, Dr. Shreyas. Very nice talk. And certainly the quality of the lens and the quality of surgery has improved so much that one can offer it to more patients.